I wanted to welcome everyone to our webinar. My name is Emily Hostetler. I am the marketing director for Phagenyx. And you've joined us for the Advancing Dysphagia Management webinar. We have a really diverse group here on the webinar. So we saw registrations come in from various parts of the globe, actually, all the way over to Asia. So it's possible we have some live participants who are starting their mornings on the other side of the world, and a diverse group of clinicians as well. So we have some researchers. It looks like we have quite a few speech language pathologists and speech language therapists, along with some nurses and some physicians. So really excited that everyone was able to join us this afternoon, this evening, this morning, either live in person or by watching this recording after the fact. So I want to hand it over to our speakers, Anna Marie and Jamie, who are the clinical experts in the room right now, and they are going to kick things off to give you an introduction to PES.
Great. Thanks for the introduction, Emily, and thanks everyone for joining us as we introduce Phagenyx and pharyngeal electrical stimulation. So my name's Anna Marie King. I'm a clinical specialist for Phagenyx and an acute care speech pathologist by background, largely coming from the level 1 academic acute care setting. I'm based outside of Pittsburgh and largely cover the Northeast and this mid-Atlantic kind of area. My colleague, Jamie Collins, is also joining us. She's also a clinical specialist for Phagenyx and an acute care speech pathologist by background. She's based outside of Atlanta and covers the Southeast. She'll actually be moderating our chat and facilitating with our Q&A at the end of the presentation. So please type in any of your questions in the Q&A function at the bottom of your screen, and she'll try her best to answer all of them live, as many as she can. So first, just taking a few steps back here before we get started, I just want to review a few terms that you'll hear throughout this presentation. So Phagenyx is the company that we work for. We're a UK-based company, and we've been there and in Europe for several years. We received FDA clearance in fall of 2022 and really just started launching commercially in the United States last year. Phagenyx is the name of our technology. So that's the system that consists of a neurostimulation treatment catheter and a base station. And pharyngeal electrical stimulation, or PES, is the treatment that we're providing. So you'll hear those terms throughout this presentation. Today, we'll explore the Phagenyx neurostimulation system, how it's an innovative solution for managing severe dysphagia post-stroke, and its clinical impact in terms of how it can be beneficial for patients as well as the healthcare system at large. We'll review the treatment and workflow, science behind PES, patient selection, and then we'll wrap up at the end with a Q&A. So by the end, you'll be equipped with some actionable insights to evaluate the potential of Phagenyx in your clinical practice and its role in advancing patient care. First, it's important to frame the problem that we're really trying to solve here. Dysphagia is a significant, expensive problem in healthcare, and that's especially true for our stroke patients, where about 50% of them are going to have a persistent dysphagia, meaning it's going to last for greater than 2 weeks. And a lot of people in healthcare just don't realize how many complications these patients really have. As SLPs, we know that these patients generally have worse outcomes. They have much higher risk of mortality, higher reliance on PEG placement, they're at risk for reintubation, increased rate of respiratory infection due to their poor airway management, and all of this can lead to higher readmission rates or other complications. So even just looking at the right-hand side of the screen here, this is called MedPAR data. It's the most readily available 2023 Medicare data. And even just looking at length of stay for these patients, patients coded for stroke with dysphagia with need for vent support or tube feeds have about 11 days longer length of stay. And this can really add up over time. This will actually increase their cost of their care by over $40,000 per patient. So these patients are expensive. They require a lot of our resources for their care. And this can certainly add up if you have a high stroke volume. Swallowing is one of the most complex processes in the human body. And this is very much an oversimplified depiction, but essentially we have sensory nerves in the oral cavity, the pharynx, and the esophagus that send afferent sensory signals up to the cortex and the brainstem, which then analyze that and send efferent motor signals back down to either contract or relax the swallow muscles. Anything along this pathway could be damaged and could result in a neurogenic dysphagia. There could be a central injury, such as following a stroke or a traumatic brain injury, or there could be a peripheral injury, such as due to disuse atrophy or intubation. And oftentimes, our patients have both peripheral and central injuries, presenting with a complex and severe dysphagia. So what are we currently doing to treat patients with dysphagia? As SLPs, the answer is we're doing what we can. The current evidence base is pretty limited, especially in the acute care setting. So there are really two major groups of interventions that we typically use. The first being our compensatory strategies, like our postural changes or diet modification. And then the second being our rehabilitative intervention. So that includes our exercises, things that are intended to improve sensory motor control system through improving muscle performance or skill. So here we're doing exercises peripherally to try to facilitate neuroplasticity, but we're not doing anything directly to the brain itself. These interventions are usually motor-based and require active patient participation too. And really, a lot of our patients in the acute care setting just can't do that. They have cognitive communication deficits, they're confused, they're too lethargic. So for some of these patients, there's not a lot that we can do. And that often results in this watch and wait type of approach where we know they need early intervention. They're just really not appropriate for what's currently available. And that brings us to Phagenyx. So I'll talk about the mechanism of action more on the next slide, but here I really want to focus on the piece that's currently missing in our toolbox as SLPs. Phagenyx induces and accelerates neurological recovery, reestablishing the connection between the sensory nerves and the brain. So unlike other dysphagia interventions that use motor and skill-based practice to improve swallow function, Phagenyx uses sensory stimulation to treat neurogenic dysphagia at the brain level by facilitating cortical excitation to drive neuroplastic changes. As a result of inducing neurological recovery, this then has downstream effects for improving and maintaining long-term muscle function. So while there's data to support the early, intermediate, and late use of Phagenyx to treat neurogenic dysphagia, we do encourage the early use of this intervention when neuroplasticity is heightened and dysphagia risk and health complications may be more critical to the patient. So this really results in a paradigm shift where we can potentially treat some of these patients earlier in their care continuum. We're essentially acting as a neurorehabilitation technique with the intent to jumpstart neurologic recovery to help facilitate downstream muscle rehabilitation. Phagenyx induces and accelerates neurological recovery, reestablishing the connection between the sensory nerves and the brain. And this is really just a missing tool in our SLP toolbox, right? So nothing like this exists for us beyond this technology. So with that being said, this is meant to be in addition to everything else that you're doing for these patients. So going more into the mechanism of action here, the Phagenyx system consists of a neurostimulation treatment catheter and a base station. The catheter is placed like a standard NG, just with a few nuances, and it has two bipolar electrodes that sit between C3 and C4 on the posterior pharyngeal wall. So we're targeting the pharyngeal plexus, specifically sensory nerve fibers of glossopharyngeal and vagus nerves. And that's where a very low level of stimulation of 5 hertz is delivered, and it's delivered at a patient-specific intensity. This is measured by the base station, and it's optimized before every treatment session. With the treatment session lasting 10 minutes, the stimulation is being delivered for 10 minutes. We know that this powerful afferent signal has been shown to increase cortical excitation in both the damaged and undamaged parts of the brain. We have fMRI and MEG imaging to show excitation of the swallow motor cortex, which subsequently drives neuroplastic changes. That cortical excitation is what facilitates neuroplasticity, where undamaged parts of the brain are taking over swallowing control, so that ultimately we're treating the root neurological cause of the dysphagia. And this mirrors what we see in natural spontaneous recovery. So we're essentially expediting that process by rewiring the brain for swallowing control. So it's reestablishing the neurologic loop and those efferent output signals from the brain to the brainstem and the muscles. And then downstream, what we're seeing is an improvement in a large range of swallow outcome measures. In addition to the central mechanism of action, we do also have a peripheral mechanism of action via a neurotransmitter called substance P. For those who haven't heard of it, substance P is a neurotransmitter that's associated with positive cough and swallow outcomes. And we do have publications that have demonstrated an increase in substance P following PES. So this could almost act like a biomarker of treatment success. Taking a closer look at the components of the technology, the primary function of the dual action neurostimulation treatment catheter is the treatment, PES. It does also dual as a feeding catheter. So a lot of these patients need feeding tubes for nutrition, hydration, medication. So this is a great secondary bonus function of the catheter to support those needs. The catheter itself is adjustable to meet the patient's individual anatomy. So essentially there's an outer sleeve where those bipolar electrodes are housed. This is essentially wrapped around the inner core feeding portion of the catheter. So with this design, we're able to ensure the distal end is in the correct position for the purpose of feeding, while ensuring that the electrodes are in the appropriate position for the purpose of the treatment. And then down below here, the base station, this is where the stimulation is actually being provided. That's the unit that's brought to the bedside by the SLP and where we provide the patient-tailored stimulation. So big picture workflow, this integrates really nicely into acute care settings. Typically, SLP is already completing their clinical swallow evaluation and instrumental assessment per standard of care. From there, SLPs collaborate with the medical team to determine if the patient is a candidate for treatment. Next, the catheter is placed just like a standard fine bore feeding tube with a guide wire, just with some nuances. And typically, whoever's placing NGs at your facility, so generally nursing, providers, or sometimes dietitians, they would be the ones to place this catheter. From there, the catheter is ready to use for treatment, feeding, and medication, and it can be left in place for up to 30 days for the purpose of feeding. SLP can then begin sensory optimization and the treatment. Again, the frequency that's being delivered is 5 hertz, and that never changes, as that's what's demonstrated to promote the greatest cortical excitation. But what does change is the intensity or the amplitude of the wave providing up to 50 milliamps. Patient stimulation is then tailored before every treatment session, and the regimen of treatment is 10 minutes a day for 3 consecutive days, up to 6 days. So, to summarize here, nurses or providers are generally the ones placing the catheter. Dietitians manage feedings as usual, and SLPs are completing their clinical swallow evaluation, instrumental assessment to facilitate with patient selection. And then from there, SLPs are the ones providing the treatment. The treatment itself in total, including that sensory optimization component that I briefly described, takes about 15 to 20 minutes. So now we'll get into the science and support of pharyngeal electrical stimulation. The treatment itself has been validated by over 30 years of research, starting with foundational work done by Dr. Shaheen Hamdi and colleagues in the mid-90s. And that's what really led to PES as a viable treatment option. The central and peripheral mechanisms of action behind PES with subsequent treatment and dosage parameters have all been studied extensively, resulting in both scientific and clinical validation. These optimal treatment parameters were what demonstrated the greatest cortical excitation and related patient outcomes. There was then further clinical validation of PES that continued with additional studies, linking improved swallow outcomes like improved swallow timing, improved secretion management, return to oral intake, with economic health benefits like reduced feeding tube dependency and length of stay reduction. So across our over 30 publications and 9 RCTs, both sponsored and independent, and thousands of patients treated commercially to date, there have been 0 serious adverse events ever reported regarding the stimulation. So here I want to emphasize that the mechanism behind this is really quite safe. And all of this data is what led to FDA clearance in the United States, which included a de novo classification, which essentially indicated that this technology is the first of its kind. While we have data in a range of patient populations, the FDA determined that our stroke data was the strongest. So currently, that's our indication in the United States. Which brings us here to our FDA clearance. So our FDA clearance, as stated, the Phagenyx system is a neurostimulation device delivering electrical stimulation to the oropharynx to be used in addition to standard of care. So here I want to take a moment again to emphasize that we're not taking anything away from SLPs and what they're currently doing. And we actually couldn't possibly, because this is a completely new mechanism of action that we didn't have before as we're treating the root cause of the neurologic dysphagia. I will also mention, because I know that there's a broader global audience joining us, that our indication in Europe does include all neurogenic dysphagia. So how does this translate to selecting the right patients? Here we've provided some characteristics that you might look for. These are all based on our studies and includes things like poor secretion management, risk of intubation, trach patients who are unable to be decannulated, impaired airway protection, significant pharyngeal residue, and patients who are at risk of PEG placement. Additionally, if patients aren't able to participate in our traditional therapy, such as due to their cognitive communication deficits, or maybe from a physical standpoint, or if they lie in that watch and wait type category that I mentioned earlier, then PES could be a good option for those patients because they don't have to be able to follow commands for the purpose of the treatment. And again, this is part of that paradigm shift and the missing tool in our SLP toolbox in several ways. With the first being that now we have an option to treat patients who can't participate in our compensatory strategies or rehab interventions. And 2, that we can now more effectively treat swallowing, not just for the purpose of being able to eat and drink again, but also for the purpose of improving airway safety. As we know, poor secretion management can lead to intubation, reintubation, or difficulties with trach cannulation, for example. And patient selection is also really where our team of clinical specialists, who are all SLPs, this is where we can help to provide customer support. So if there are any questions about patient candidacy, et cetera, we usually work very closely as part of that team. So hopefully now you have a better understanding of what PES is and how the Phagenyx system can be integrated into your existing dysphagia care programs to accelerate dysphagia recovery in patients post-stroke. Both central and peripheral mechanisms of action have been validated scientifically and clinically and correlate with improvement in a large range of swallow outcomes. Most importantly, these improvement in swallow outcomes have been linked in the literature to reduce cost of care, ultimately leading to higher quality of life for our patients and reduced burden on the healthcare system. So what we're seeing in the United States so far really largely mirrors what's been captured in the literature and throughout the commercial use in Europe. We're seeing things like faster time to oral diet, faster diet advancement, improved secretion management score, reduced length of stay, intubation avoidance, and PEG avoidance. We've also received positive feedback from our US sites that have been those early adopters of Phagenyx, really about the multidisciplinary impact of the treatment. So SLPs, for example, it provides them an option to treat those patients who typically can be challenging, that those watch and wait type patients, or even our lateral medullary stroke Wallenberg patients. For the patient's care team, so individuals like physicians, providers, nurses, it really provides visibility now that patients can be addressed much quicker and potentially have reduced burden of care given their positive response to the treatment. Okay, and then before we wrap things up with our Q&A here, we just wanted to list our socials. So if you'd like to connect on LinkedIn or follow us on Instagram. And then if you're interested in introducing Phagenyx to your institution, please feel free to put your hospital and email down below in the Q&A section. And we can have one of our sales representatives reach out, or you can reach out directly to the email listed on the screen here, contact@phagenesis.com. So I'm sure during this time, Jamie has been really diligently working to address some of the questions in the Q&A. And we'll see maybe some trends that we've seen throughout our time here.
Yes. Really good one here. We've had some questions about differences between PES and like different other types of neuromuscular electrical stimulation. Things like, I guess, like Vital Stim, Amp Care. So if you could maybe just review like the differences between those modalities.
Yeah, definitely. That's a good one. So the mechanism of action behind PES is really fundamentally different than that of NMES. And that really reflects that they're targeting two different things, right? So Phagenyx functions as a neurostimulator, where we're delivering a very low level of internal stimulation to activate sensory pathways and promote cortical excitation. Whereas in contrast, to my understanding, NMES is a muscle stimulator that's designed to deliver very high intensity external stimulation with a goal of muscle contraction for the purpose of strengthening. So hopefully that better describes how the mechanism of action between those two things are distinct. And that's not to say that a patient couldn't potentially receive PES and something like NMES.
Here's another really good one. What type of training is required to deliver Phagenyx?
Yeah. So we actually come on site and we complete comprehensive training. So clinical specialists like myself and Jamie, who we're all medical SLPs by background, we come on site to support patient selection, catheter placement. We train for the delivery of the treatment itself, and then really any other logistics. So whether that be things like technical support, education for the team at large. It's a multidisciplinary process. So we really try to touch base with anyone who might be involved in the patient's care. So SLPs, providers, nurses, dietitians, receiving at least a level of education and then more formal training for some. I will also mention we do provide support for billing and reimbursement as well. And that in total, like all of this kind of support that I described, it doesn't stop just after the training. Like just once training is done, it's not like we walk away. It really is like a partnership. So I know that like Jamie and myself, we're in pretty constant communication with the hospitals that we're currently working with.
It is definitely a partnership. All right, let's see. Let's see. Oh, here's a good one. Do tube feedings need to be stopped to administer the treatment?
That is a good one. The answer is no. Tube feeds can be running during the treatment itself. I will say, of course, if you have a patient who maybe's had some recent nausea, vomiting, could be a good idea to just proactively pause tube feeds. But otherwise, it's not like they have to be stopped every treatment.
Let's see. We've also had a few questions about does the catheter stay in for multiple days, or is it reinserted for each treatment? Like if they already have a peg or, you know, already have it in place.
Yep. So the catheter would stay in place for the duration of treatment. So those 3 to 6 days, depending on clinically what's indicated. And then it can stay in place for up to 30 days for the purpose of feeding.
I've actually had quite a few questions about electrode placement. How do you know like the electrodes are in the correct location in the pharynx?
Yeah. Let me scroll back here because I feel like it's easier to see with visual. There we go. So here you can see the catheter internal to the patient. Here are those 2 bipolar electrodes that I described earlier that sit in that C3, C4 region. And then you'll notice there are various markings on the catheter itself. So first, external to the patient, there are these black nasal guides. And this is really our primary check to ensure that the electrodes are in the proper position. Internally to the patient, you can see there are green oral guides. If the patient's able to follow commands to open their mouth and you can visualize the green oral guides, that's like a secondary kind of check. And then as far as the stimulation goes in general, it's really more like a field of energy. So as long as we're in that C3, C4, pharyngeal plexus kind of region, really we're good to go. It's not something that's so localized, like something like a deep brain stimulator would be, for example. And then also the base station is continuously monitoring for electrode contact as well.
Getting a few questions as well about, I'm going to condense some of the questions that are popping up in the chat that can kind of be addressed in all at once. So questions about like, are there any contraindications for consideration, any side effects, things like that?
Okay. So as far as contraindications, our catheter is not currently MRI compatible. However, I will say this hasn't been a significant barrier to treatment because typically SLPs and providers are really having these conversations about the patient's plan of care on the front end before we're really ever pursuing treatment. Another one is active implanted electrical devices. So things like pacemakers, those are technically contraindicated as a theoretical risk because it would be essentially impossible for us to test like every type of device, every type of pacemaker that's out there on the market. So therefore, we can't definitively rule out risk. And then finally, pregnant women and children, Phagenyx hasn't been tested in those populations, so they're also considered contraindications. And then I believe your second part, Jamie, was that side effects. Just
Mhm.
okay, yeah. So there are a few side effects. They're readily reversible. The first, and they just occur during the 10 minutes of stimulation itself. So the first is ear pain or jaw chattering, and that's theoretically because the electrodes are sitting a little high for the patient's individual anatomy. So it's really just adjusting the catheter a bit to mitigate that. The second is arytenoid edema, and that could be present with any indwelling catheter. And then the third is hypersalivation, which is just, again, it's just during the 10 minutes of treatment, and that goes for the ear pain as well. So typically we just encourage having yank or suction set up and ready to go so that if the speech pathologist needs to facilitate suctioning or the patient needs to suction, then they can suction during the treatment. And then once treatment is over, it's really just moving on. That resolves.
Getting some questions as well about like going a little bit more in depth about like what does the treatment session look like, specifically like the sensory optimization that's performed prior to treatment. If you
Yeah.
could elaborate on that a little bit.
Yeah, definitely. So sensory optimization happens before treatment every session. So first the SLP goes in and we do threshold testing, which is essentially the first time that a patient feels anything at all. So if it's a patient who's able to communicate that to you, they're doing something to indicate that they feel something. If it's a patient that can't communicate that, maybe they have global aphasia or they're just not super reliable in their response, then you're looking for a spontaneous swallow. From there, we move on to tolerance testing, which is the highest amount of stimulation that the patient can tolerate. Again, up to 50 milliamps, that's the maximum of the device. So same thing there, the patient is either communicating that to you or you're looking for any like nonverbal changes, anything that you didn't appreciate when you first walked into the patient's room. So things like a patient getting kind of wiggly in bed, eye widening, reaching towards their throat, really anything to indicate that there's been a change. From there, you then have the opportunity to test the stimulation so the patient knows what to expect for the duration of the 10-minute treatment before moving into that full 10 minutes of stimulation.
We've had some questions about like, since you mentioned using this as an early intervention, just how early can you treat with?
Yep. So you can start treatment as early as 24 hours post-stroke. On the other end of the spectrum, I will note that we do have efficacy data as well in our subacute or chronic phase of recovery. So data up to a year and a half post-stroke.
Okay. Sorry, guys. Y'all are asking some really good questions. I'm just trying to condense
You're doing
everything.
great.
Trying to be mindful of time. Let's see. Oh, here's a good one. What does PES treatment feel like? Like for the
Oh
patient?
yeah. Yeah, we get asked that one a lot. And really the answer is it's different for every patient. And that largely reflects, it just depends on the level of the patient's sensory impairment, right? So for some patients, they'll report feeling nothing at all during the treatment. Other patients, they'll describe more of an intense feeling in their throat, often describing it as like a pulsing, a tingling, a buzzing. Those are like kind of key words that I feel like I get a lot when collaborating with SLPs and their patients. And then the other thing I'll note is that I described that sensory optimization earlier, and that's ideally where we're kind of managing that as far as making sure that the patient is comfortable for every treatment.
Mhm. I always think it's a fun observation, you know, when you're on site and you're watching a patient treatment and, you know, they're so sensory impaired that like 5 minutes into the treatment, all of a sudden they're like, my throat feels funny.
Oh.
Because all of a sudden they're starting to feel things again. They're reconnecting that sensory motor loop. So it's just kind of funny to watch that progression sometimes, like throughout their treatments, as they're gaining that sensation that they go from not feeling anything at all to all of a sudden they're noticing that things feel different. All right. Let's see. What about we're getting some questions about the cost. The cost of the system.
So I will say, I know that we have like a pretty diverse group with us. So since this is a global audience, I would say the best way to really accurately answer this, because I don't want to steer you the wrong way, would be to get in contact with our team. So again, feel free to share your hospital and email below, or you can directly contact at phagenesis.com, which I'll kind of scroll back again now. There you go. So that's the email on the screen to use globally.
All right. What about so does the type of stroke matter? Like the hemisphere, what type of stroke? I'm getting some questions about that.
So the answer is no. There are no significant outcome differences across stroke type or location per sub-analyses of our studies. So that includes left versus right. There's no significant difference. Supratentorial versus infratentorial, same thing, no significant difference. And ischemic versus hemorrhagic. So potentially any of those types or locations, those patients could be candidates for treatment.
Yeah, and I think just anecdotally here in the US, I think we've had some really nice success stories with those medullary patients. Yeah. Which, as we know as SLPs, they can be really difficult to rehabilitate, very slow to recover. So that's another really cool population to again see that progression with their recovery. What about getting some questions? There must be some nurses in the crowd. I'm getting a lot of questions about the placement of the catheter. So should you confirm placement with an X-ray, like how most hospitals require for NG tube placement?
Yes. Yep. So once the catheter is placed, you would then confirm just per your standard practice. So typically a chest X-ray or a KUB. From there, you're good to remove the guide wire and then begin treatment, feeding, medication, etc.
What about during the actual stimulation? Can the patient swallow liquids or solids during the treatment, or do they do exercises during it?
Yeah, that's a good one. So PES is different than any other intervention in that it works by inducing and accelerating that neurological recovery, right? So we're helping to reestablish the connection between sensory nerves and the brain. So you could almost think of Phagenyx as like a priming therapy to be used prior to some of those rehab techniques or therapeutic trials. And again, it's meant to be in addition to everything else. So while the patients don't complete PO trials or exercises during the treatment, it could be completed at a later time, right after the treatment. And then the other thing I'll mention is that during the stimulation, you may see increased swallow frequency as a result of restoring that sensory motor integration. So while it's not really our primary goal, it is a really nice secondary kind of bonus to see this increased swallow frequency in those patients.
Mm-hmm. Yeah, that's something I've definitely received some feedback from when I've been on sites that, SLPs will comment oh my gosh, prior to this, it took me 20 minutes to get 5 spontaneous swallows, to try to work with this patient. But now, during the treatment, we're getting say 30 swallows in 10 minutes. And then it continues even after the treatment. So they can actually do more effortful swallows and things like that. So it's just a really good neuropriming tool essentially to help jumpstart our patients. All righty. Yeah, so we trying to get to all of these these questions. Just to be mindful of time, this may be our last one. Let's see. I'm gonna try to pick a good one for y'all. And then if we can't, if we're not going to address all of these, then we'd have your usernames. We can definitely follow up individually. Or if you think of anything after the fact, then you can always submit a question through contact@phagenyx.com. What about, let's see, we're getting some questions about like the results, like, are they permanent? Like, do you have to do maintenance therapy? Things like that. You could elaborate.
Yeah. So yes, the results are permanent. So again, we're really accelerating that neurological recovery, and we've seen sustained benefits over time without the need for additional treatment. Generally speaking, we see clinically meaningful improvements in 24 to 72 hours after the last PES session. And with that, the effects can be cumulative. So we actually may see even continued improvement over the following weeks. And then more on the clinical research side, nearly all of our studies have followed patients at least 30 days following treatment, sometimes longer. And within that, there have been no concerns for, like a patient's improvement and then a regression or anything like that. And then all in all, this kind of goes back to some of our foundational work, which I didn't get into too much today. But essentially, they found that when they did brain imaging after the therapy, those changes persisted over time.
All right. Yeah, so I mean, these are excellent questions. I'm really impressed with the level of engagement and the questions we're getting. So like I said, we will definitely follow up with some of these individually that we couldn't get to. And then if you think of anything after the fact, just email us at contact@phagenyx.com. And I will turn it over to Emily now for any last closing remarks.
Oh, I should think of something inspirational. I think what I would like to say is thank you to both Anna Marie and Jamie for an excellent overview on PES. I'm so happy to see the level of engagement we have from attendees and how many people have stuck around with us to the end. One of the things I did want to note for this group, since again, we have quite a few people coming into this webinar from global markets, is that right now PES and Phagenyx is available in the US, UK, Ireland, Germany, Switzerland, and Austria. Those are our current markets. So obviously we are a growing company and we're looking at where we're going to go next and make this technology available. Given the level of support that we do provide sites, it's something that we need to be really mindful of as we grow, because we need to make sure that we're able to support sites appropriately. But we definitely still want to hear from people who are interested in the technology, and that way we can update you as we have some changes to availability and grow with the markets. In the meantime, again, definitely follow us on LinkedIn if you don't already, and Instagram. That's where you'll see news and events. And you've heard the email address before, but I'll say it one more time before we say good night, good afternoon, good morning, and that's contact@phagenyx.com. So thanks everyone for joining us, and we welcome any questions via email, and we'll be happy to follow up as soon as possible. Thanks so much.
Thanks, guys.